United States Department of Agriculture.
So thank you for the introduction. Good morning, everyone. Firstly, I would like to thank the symposium organizers for the opportunity to present this work. Today, I will present our last publication entitled Cecal slurry as an alternative model to cecal ligation puncture for the study of sepsis-induced cardiovascular dysfunction. So sepsis is characterized as a dysregulated ROS response to infection, leading to organ dysfunction. Septic shock is a worsening of this condition that occurs when severe and persistent hypotension leads to hypoperfusion and eventually to organ multiple failure. These conditions represent the main cause of death from infection in hospitals. Only in 2017, around 49 million cases and 11 million deaths were estimated worldwide. The current treatment of these conditions is made with antibiotics to contain the infection source, but even after the resolution of the infection, hemodynamic changes may persist. Therefore, fluids can be administered intravenously to increase blood volume and consequently cardiac output and blood pressure. This is called volemic resuscitation. Also, vasoconstrictors such as norepinephrine are used when mean arterial pressure does not reach 65 millimeters of mercury. However, even so, many patients do not respond to these strategies. And this occurs because the cardiovascular system is very affected. In the cardiac tissue, sepsis leads to decrease in cardiac contractility and mitochondrial dysfunction. And in the vasculature, sepsis induces vasodilation, impairment of vasoconstrictor response, also called vasoplegia, loss of barrier function, which increase permeability, among other changes. These factors together make it difficult to reverse the drop in mean arterial pressure. Therefore, experimental models are useful to clarify the mechanisms of injury of this complex pathology and to point to new pharmacological targets. Cecal ligation puncture, CLP, is the most used model to induce sepsis. It consists in opening the abdominal cavity, exposing the cecum, perforating it, and spill over the cecal contents into the peritoneum, inducing a polymicrobial abdominal sepsis. However, CLP has major drawbacks: variations in the ligature length, needle size, and the amount of the extravasated cecal contents directly affect the outcome of the sepsis model. That is, it is subjected to high variability. Additionally, it is a highly invasive model that demands surgical training and anesthesia. Therefore, the title of gold standard model has been questioned, and several authors have recognized the need to refine this experimental model. In this work, for example, authors state that the unnecessary pain and the lack of quantification of bacterial load are sources of variation in the experimental sepsis. And in this context, Cecal slurry model, CS, is an alternative model to refine experimental sepsis. It consists of an intraperitoneal injection of a standardized amount of cecal contents, also inducing a polymicrobial abdominal sepsis. So this model allows the quantification of bacterial load, and importantly, it is a non-surgical and consequently less invasive model. However, as we can see in this graph, the number of publications over the years related to CS model is much lower than CLP. Then the major drawback of this model is that it is much less explored in the literature, especially concerned to the cardiovascular changes, limiting its application. Therefore, this work aimed to answer this question: is the cycle slurry an alternative research model for studying sepsis-induced cardiovascular dysfunction? To do this, we aim to standardize CS model in rats to assess sepsis-induced cardiovascular dysfunction and to compare CS with the gold standard model CLP. To answer these questions, we use male adult Wistar rats. The CLP protocol were performed as previously described in the literature under isoflurane anesthesia. On the other hand, we did not use anesthesia in the CS model. And for the preparation of the slurry, secum were collected from donor rats. And importantly, in the present study, we used a total of 5 secums of animals that would already be euthanized and were not submitted to an intervention. So in this case, our donors were control animals from behavioral studies of our program, which is a good alternative. So in the sequence, the cecal content were mixed with saline solution and glycerol, filtered and frozen until the application. We also used the same analgesic and volume replacement protocol in both models to keep the same conditions. Moreover, use naive animals, that is, animals without any intervention, as control when necessary. Then, after sepsis induction, some analyses were made after 6 hours, but the most analyses were made after 24 hours, time that cardiovascular changes were already widely described in the literature for CLP model. In addition, in some experiments, survival rate was assessed by 5 days. In our first results concerning the dose of cecal slurry suspension, we tested 3 different doses, and we observed that the survival rate induced by 1 gram of cecal contents per kilogram of body weight was near 50% within 5 days, while doses of 1.5 and 2 grams per kilogram of CS induced a higher mortality rate. And the survival rate obtained by the application of this dose was very similar to that observed in the CLP model that in this graph are present as the purple line. Then we used this dose for all further analysis. So from here, the results in purple refer to CLP group and those in green to CS group, while control group is represented in white. Then, after defining the dose, we confirmed that the mortality rate was due to sepsis, as well as the application of antibiotics reduced mortality significantly. Moreover, this axis represents the colony-forming units, indicating that there was bacteria growing in peritoneal lavage, blood, and tissues homogenates 24 hours after the intraperitoneal injection, indicating bacterial dissemination. These results so confirm that we are injecting viable bacteria in the animal. Sepsis score describes qualitative parameters of the animal as described in this study. So 7 parameters were evaluated: the appearance, level of consciousness, activity, response to stimulus, eyes, respiration rate, and quality. We observed an increase in sepsis score already at 6 hours and 24 hours after the sepsis induction, in both sepsis models in a very similar way. Lactate concentration is a biomarker that are increased in patients with sepsis and septic shock due to several reasons. It is considered a warning sign of hyperperfusion and is usually associated with organ dysfunction. We measured blood lactate values over time in the same animal and observed that lactate levels were increasing in both septic models 6 and 24 hours after the insult. Nitric oxide plays an important role in sepsis. The increased expression in the nitric oxide synthase 2 is an effort to contain the infection, but it also contributes to several mechanisms of injuring sepsis, including hypotension. We observed that the products of the oxidation of nitric oxide increased in plasma 24 hours after the insult, suggesting that both sepsis models increase nitric oxide production. So, with these first results, we demonstrated that CS model reproduced important features of sepsis, such as bacterial dissemination, increased lactate levels, and NOx levels. But now I will show the most important results concerning the cardiovascular dysfunction evaluation, which is an important objective of study in our laboratory and has a major contribution to mortality resulting from sepsis. From here, all analyses were performed in a 24 hours frame. And as I mentioned at the beginning of the presentation, severe and persistent hypotension is a major problem resulting from sepsis. So we evaluated that by the carotid artery cannulation connected to a pressure transducer in animals under anesthesia. We observed a drop in mean arterial pressure in CLP group and CS group compared to control, along with an increase in heart rate in both septic groups compared to control, indicating hypotension and tachycardia. By a laser Doppler probe placed over the kidney, we observed a reduced cortical blood flow only in CS group compared to control, indicating hypoperfusion. Moreover, we evaluated the angiotensin II response that was administered by a venous access. This experiment is very important because vasoconstrictor response is usually impaired in septic patients. So we can see in this representative figure of the mean arterial pressure over the time that beyond septic animals had lower basal mean arterial pressure values, the magnitude and the duration of the pressure response was also impaired. Then we quantified that in these dose response curves, in which we observed a significant decrease in the mean arterial pressure response, along with a lower response duration to this vasoconstrictor in the septic groups compared to control. Same results were observed to phenylephrine, a vasoconstrictor that is also widely used in sepsis studies. So this is the line of control group, and the arrow indicates the response of CS group for mean arterial pressure and the duration of this pressure response. Then the Stachel-Slurry model showed consistent results to this hyperresponsiveness to vasoconstrictor that occurs in clinical sepsis. And in order to investigate if this hyperresponsiveness was related to a hyperactivity of the vasculature, we assessed the contractile response to phenylephrine in aortic rings. In these representative figures of the contraction over the time, we can see that septic animals showed a decrease in the contractile response to cumulative doses of phenylephrine compared to control. And in the concentration response curves, the contraction was significantly lower in both septic groups compared to control, without difference between CLP and CS models. Additionally, when we evaluated these concentration response curves individually, we saw that there was no change in potency represented by the log of EC50, but there was a reduction in the efficacy of this vasoconstrictor represented by the Emax value. So these results indicate that both models simulate the vasoplegia that occurs in sepsis. Therefore, it was already known that CS model have some advantages compared to CLP, like the low invasiveness, the lack of surgical procedure, and the standardization of bacterial load. But until now, it was not clear in the literature if CS model reproduced the cardiovascular changes that are observed in sepsis. And with this work, we concluded that Sickel-Slurry model consistently reproduced the cardiovascular dysfunction that is observed in clinical sepsis, representing a less invasive alternative sepsis model. Then here I briefly summarized this work, but for those interested in knowing more details, here's the full work and also my contact. So I would like to thank the professors and all my colleagues of my laboratory at Federal University of Santa Catarina, especially Professor Daniel, who is the principal investigator of this work, and the funding agencies and the Center of Alternatives to Animal Testing for the great opportunity. Thank you for your attention, and I'm now open to questions.
USDA is an equal opportunity provider, employer, and lender.